Hello, everyone, and welcome to another segment of the PF Warriors video series, Lessons Learned, sponsored by FibroGen Incorporated, a leading science-based biopharmaceutical company discovering and developing a pipeline of first-class therapeutics. I'm Shelley Mathis, Executive Director of the PF Warriors International Support Group, and we will be posting these video shorts weekly to educate you and inform you of interesting things going on in the world of pulmonary fibrosis and interstitial lung disease. Today, I'll be interviewing a new member of the PF Warriors, Susan Miller, who just joined us a few weeks ago and answered our request to volunteer to help with our many initiatives. When we learned about her 48-year nursing background and her diagnosis of IPF, we were instantly interested in learning more about her. Susan worked mainly at Johns Hopkins Medical Institutions, focusing on neuro-ICU as a clinical nurse, then as a nurse coordinator for a geriatric research program sponsored by the Robert Woods Johnson Foundation. She provided home infusion therapy, chemo infusions, parenteral nutrition, antibiotic and hydration therapy to patients at their homes. Those experiences led her to hospice, where she was an admissions nurse, then clinical manager. So we realized that her experience, especially hospice, could teach us a lot about the final days of what we will all experience. Susan Miller, welcome to Lessons Learned, and thank you for joining us today.
Thank you so much for having me. I'm happy to be here.
First, tell us the difference between palliative care and hospice.
Okay, there is a difference, but it's not a huge difference. Palliative care is supportive care, and it is geared towards taking care of symptoms such as shortness of breath and pain. And you get the services provided from hospice also. But the thing that is different about palliative care, that while you're getting these services, you can also still get your treatment, whether that be chemotherapy, radiation, blood transfusions, things that typically stop once you go to hospice. When you're in palliative care and while you're getting this treatment, as things may, as expected, deteriorate, it is then discussed, do these patients want to continue going to the hospital? No, they don't want to do that. They want to be comfortable at home. So that's when hospice is offered. But these are advanced diseases, chronic diseases, and life-limiting progressive diseases. And palliative care you can get anytime. You don't have to reach a certain place in your disease to get it. It's not about the prognosis, it's not about the disease, it's about keeping patients comfortable and in control of their plan of care.
Thank you. And I've actually seen some patients do a little bit better when they got on hospice and last a little bit longer.
They absolutely do.
Yeah, you mentioned to us that there were a lot of myths circulating around about hospice care. I think I've heard some of them, but would you please tell us what those myths are?
Yeah, some of the myths are you have to have cancer to be in hospice, which is not true. There are many life-limiting progressive illnesses that can get you into hospice. The other one is that you go there to die. That's all. That's what it's for. It's to go there to die. And it absolutely is a place where you go to have your life, the quality of your life improves. And that's with the team and with the medications and all the services provided. You have to have a caregiver to be in hospice. That is not true. You can live alone. There are services that are offered on the hospice team. Another big one is that hospice will only treat the symptoms of your terminal illness, and that absolutely is not true. You are treated as a whole, your mind, your body, your soul. They do treat that disease, but anything else that happens to come up that needs treatment, that is included.
Oh my goodness, that is such good news to hear. But how do you know when your patient is ready for either palliative care or hospice? And how do you explain it to them without scaring them?
Well, that's kind of a hard part, because when you start talking about hospice, you don't really know where they are mentally with that disease. But usually it comes up when they start going to the hospital more often. Oftentimes they'll have 3 or 4 admissions in 1 month because they're short of breath, because they've put on a lot of fluid, because they're in pain. What happens is they go to the hospital, they get lots of tests, lots of blood work, new medications, they come home. It's a mess at home. They don't know about their medications. So at that point, it's a good place to introduce hospice. Do you want to go back to the hospital the next time you're short of breath? More times than not, they say no. Please don't send me back to the hospital. Have you thought about hospice? Let me tell you about hospice. And our goal is to improve your quality of life. And when you get short of breath at home, we have medications, a comfort care kit that you will be educated on if you want to be, or your family, and that will help keep you at home. But that's usually when you start looking for more services or different medications, then that can be a good time for hospice to be introduced, or palliative care. And palliative care you can do early in your disease process. It doesn't have to be towards the end of life.
When somebody's in palliative care, is their caregiver expected, or the family expected, to do anything in particular? Or does the caregiver get some training as to, here's what you do, either in palliative care or in hospice?
Well, it's different. When you're in palliative care, you're a little bit more active. Like you go to the palliative care physician's office. They don't come to your home unless, but as you decline, that would happen. But that's when you would also go into hospice. Everything is reviewed with the family. When you are in hospice, you are given a comfort care kit, which has 6 or 7 medications in it. These medications help with shortness of breath, agitation, nausea, vomiting, pain. The medications are all oral, they're liquid. The family is instructed on that and how to give it. And oftentimes they're very fearful to do that because they don't want to overdose anybody. So there is a lot of teaching with that. And every visit that the nurse makes, that is reviewed to make sure that the family is comfortable with what they need to do.
I've heard people talk about paying for care, end of life care. Who pays for hospice or palliative care?
Medicare pays full palliative care and hospice care. And a lot of private insurances also cover hospice. If you don't have any insurance, there are 2 hospices. There's profit and not-for-profit. So the hospices that are not for profit, the donations that they get from previous families and patients go towards helping to pay for hospice for those who can't afford it or don't have insurance. But Medicare pays 100%. And that includes the services, the durable medical equipment, the medications. So that's fully covered.
When the family or the caregiver is given some training, how do they handle emergency situations? And here I'm thinking about the hurricanes in Florida or the fires in California.
First of all, the electrical companies, the ones that are providing electricity to the communities, are aware of our hospice patients and the ones that are on oxygen. If they absolutely cannot be without oxygen, we will transfer them often to a hospital, or a hospital that has several beds that have been allocated for hospice patients. They have generators. So whenever there's a storm brewing, the team gets in action as to what may we need to do to take care of this patient during the snowstorm. And it's, in my experience, it's always been very successful, but you have to be prepared and pay attention to weather.
Oh my gosh, that is so comforting to hear. Well, Susan, we will all face our final days on this planet, but can you tell us what a pulmonary patient in particular will face. Is there significant pain, discomfort, or suffering? Is the family prepared for how this is going to come down?
Well, one thing that all nurses do is prepare the family as best they can, because it makes the experience a little bit easier when the family is on board and aware of what's going to happen. So with pulmonary patients, they oftentimes are not different than a cardiac patient. I mean, at the end of life, what happens is um, your appetite, you don't want to eat, you don't want to drink. Many people will say, oh, my dad needs a feeding tube, or we need to do IV fluids. And your body at this point can't accept nourishment, doesn't know what to do with it. It causes pain. So there's a lot of teaching that goes on with that. But we have the comfort care kit. We make sure that one person in the family is responsible for that comfort care kit, and we go over the meds, what they're for. We're there when they initially give it so that they understand how to give it. There's just lots of hands-on care from the nurse and going over, the symptoms that we're going to see. So there can be restlessness, there can be agitation, there can be confusion, nausea and vomiting. And the comfort care kit takes care of all of these symptoms, which otherwise would send someone to the hospital. So the families know to call hospice whenever it looks like it's really close. Breathing gets very irregular towards the end. So they may breathe 3 breaths and then stop for 30, 45 seconds, and then pick up breathing again. And sometimes toward the end, now this with pulmonary patients, you may hear a rattling. And it's very disturbing to families when you hear this. But the patient, though they look like they might be struggling, they are comfortable as long as they've been getting their morphine and Ativan. And we don't suction, so everything is about comfort. So we turn them on their side to try to alleviate those secretions, keep them comfortable, just reinforce and support the families that they're doing a good job. And we're always available by phone. It's a 24/7 team. And this team there's a physician, a nurse. Oftentimes there's a nurse practitioner. There's a social worker, a chaplain, certified patient aides, which help to come in and bathe. And one of the biggest services, which I think is one of the most important for hospice, is the volunteer services. So volunteers can come in and sit with patients or be with them while the family goes to a wedding or something else going on that no family member will be home. So there's lots of support, there's lots of coverage, and it makes for a good end of life experience.
We know that some patients struggle with breath, and it's hard to understand how we could help them. What medications really do to help them?
Morphine is the most effective medication for helping shortness of breath. It works for pain and it works for shortness of breath. What morphine does, it relaxes the bronchioles and the airways. It relaxes all the muscles. And you start out with a very small amount, but as that symptom increases, as it worsens, you can add more and more to the dose. It comes in a liquid, and it just goes either between your back teeth, your back jaw, and your cheek, or under a tongue, and it gets absorbed and it works, very quickly. But putting oxygen in the nose, sometimes families prefer to have a mask. That doesn't necessarily deliver them more oxygen at this point. But the morphine is absolutely the #1 drug that will help with the difficulty in breathing. The Ativan helps with agitation and anxiety, but usually at the end, that doesn't help as much as the Ativan. And then there are the atropine eye drops, which go in the mouth, but that helps to dry up secretions. And, just positioning the patient so that if they're on their side, anything in their mouth, because at this point they're not swallowing. And to suction someone is really pretty caustic. It's loud, it's uncomfortable. It's not something that we typically do. So we just help them by positioning them on their side or turning their head and raising their head up a little bit.
Oh my goodness, that is so good to hear. And hospice workers are truly doing the work of the angels. Thank you so much, Susan Miller, for sharing your wisdom with us today. And thanks to FibroGen for supporting us in these Lessons Learned series. And thank all of you who joined us today for this segment. Hope to see you again next week. Bye for now.